Hello friends, welcome to Pathshala. This week's case was 55 years old female presenting with persistent right hemithorax pain for last 1 year. CT revealed a mass in right lower lobe of lung. Trocar biopsy was performed. This is HE stained sections, low power view and high power view. Here you can clearly see slender spindle-shaped cells separated by loose stroma here and abundant collagenous stroma here. There are multiple thin-walled vascular channels. Some of them have hyalinized wall. Tumor cells were positive for CD34, showing diffuse cytoplasmic staining here. Diffuse nuclear staining for STAT6 was present in tumor cells. Ki67 was very low. Here you can see just a couple of nuclei showing positivity. Overall Ki67 staining was less than 4% in most mitotically active areas. Other findings included negative staining for cytokeratin, TLA1. There was focal necrosis, which was very small, involving less than 10% of the area. Mitosis was very low. There was no significant atypia. On the basis of these findings, we diagnosed it as a case of solitary fibrous tumor, which is a relatively rare type of mesenchymal neoplasm. It can occur in different locations throughout the body. However, the thoracic cavity is the preferred site. When we see spindle cell lesion, these are the differential diagnosis we have to consider. Most of these are negative for CD34 and STAT6, which is positive in our cases. In addition to that, mesothelioma will show calcitonin. NCK positivity, carcinoid will be positive for synaptophysin, chromogranin. Synovial sarcoma will show TLE1 positivity and cytokeratin positivity. Gist of primary gist of lung are relatively rare tumors and they show CD117 positivity, DOG1 positivity. Fibrosarcomas usually are more aggressive type of lesions, show more atypia, high mitosis, and negative staining for CD34 and STAT6. Solitary fibrous tumor typically have uniform fibroblastic spindle cells separated by variable amount of collagen. In paucicellular tumors, there is abundant keloidal collagen. In hypercellular, more aggressive form, there will be little or no collagen matrix between tumor cells. Myxoid stroma may be present. Usually, they are well circumscribed, and small proportion may show infiltrative margins. Mitosis is usually scant and usually there is no necrosis. However, more aggressive form will show coagulative necrosis and increased mitotic activity. Immunohistochemistry shows CD34 and nuclear STAT6 positivity. However, in dedifferentiated form, you may not find any CD34 staining. Cytologically, oval, elongated or rounded cells are present with wispy cytoplasm and eosinophilic collagenous stroma. NAP2 STAT6 gene fusion is typical of solitary fibrous tumor. However, NAP2 and STAT6 lie in close proximity on chromosome 12. So, detection of the fusion is difficult by conventional cytogenetic methods like FISH. And they also show diversity of breakpoint in both exons and introns. That makes regular PCR based detection little difficult. However, STAT6 immunohistochemistry is a very sensitive and specific surrogate marker for fusions. These are the essential and desirable diagnostic criteria for solitary fibrous tumor as described in WHO fascicles. We have discussed most of it. For risk stratification, two models have been described, 3-variable model and 4-variable model. In 3-variable model, we take patient's age, mitosis and tumor size in consideration, while 4-variable model will also include necrosis. And accordingly we score the lesion, and 3 to 4 in 3-variable model qualifies for intermediate grade, while 5 to 6 qualifies for high grade, while in 4-variable model 4 to 5 is intermediate grade and high grade is 6 to 7. According to these criteria, our case falls into intermediate risk group. treatments is usually by surgical excision. However, adjuvant therapies like radiation chemotherapy may be considered for a more aggressive form of disease. Long-term follow-up is essential because there is potential for late recurrences and metastasis. Thank you very much. Have a good day.